So thank you so much, ma'am, for making me part of this, I can say, legendary cases I saw with Dr. Rohit sir's cases and Suma madam's cases. I mean, I'm not going to have a huge, I mean, for me, I have not done a lot of oblique resurgeries. So I would be concentrating more on preventive aspect of not, going for a resurgery, because these are really, they're only the trained people who do oblique muscles. So we don't get a lot of resurgeries, and these are all peculiar muscles. Infraoblique may be forgiving, but supraoblique is not at all forgiving. So until unless we are pretty sure that we are good at it or we can do it and the patient needs it, we should not embark into it. And second thing is less is more in supraoblique. So we should, if the chicken suture was done, it is okay if there is a residual, rather than going for a supraoblique palsy, which will create bigger problems. And torsion is very difficult to manage once you do land up into supraoblique palsy. So these are applied aspects of anatomy, and this is what I was saying about preventive aspect of infraoblique. The dissections are very, very important. Not running. Oh. Video is not running. A photograph aa gaya hai. Can I use my laptop? यार मुझे मत दिखाओ, अब तो कम से कम वीडियो दिखा दो. So this, so what we do is we try to, what I always try to tell is that you hook it under direct visualization and then try to go and take the whole muscle. And once you are holding the muscle, once you have dissected the muscle, try to see whether you can see the sclera behind it or not. So once you cut this particular septum, you try to see between the two hooks if you can see the sclera or not. Only then you are pretty sure that the muscle is complete. Most of the problems normally, as we have discussed now extensively, that infraoblique is like your mother and it is a fairly forgiving surgery. So most of the infraoblique surgeries are forgiving if it is completely hooked. Yeah. So it is, jokes apart. So if there is persistent overaction of infraoblique, there has to be some part which has been left, or you have done little less for, what I mean to say is that your surgical dosage is a little less. Hooking is crucial in primary surgery. There have been, there is a good article in AJO on multiple bellies or insertion, and a weaker procedure could have been done for a larger overaction. So what is to be done is that if there is a mild to moderate overaction, still there is a persistent of that, you can do an enterization. You can pull it little anterior. Newer insertion can be more anterior, or you can go for if there is a severe overaction, you can go for a nasal enterization. There is no hypertropia. My surgical choice would be myectomy. Now this is when you have slightly overdone the infraoblique, or you are going for unilateral surgery and you have done infraoblique enterization. This is basically a co-contraction syndrome, as Dr. Rohit showed one patient where he did a total anteropositioning of total enterization of infraoblique. What happens is when patient tries to look up, both superior rectus and infraoblique are contracting. So it is more like a co-contraction syndrome where elevation would be restricted and there will be more of a Y pattern. So there will be very minimal infraoblique overaction in the adduction, but when the patient tries to look up, there will be a good amount of lag in that. So in some of the patients, we have done. I'm a very big fan of adjustable. And all the patients which I was looking, as so many surgeries were done, I would always go for an adjustable. And even for infraoblique, I've tried out adjustable infraoblique surgeries. In patients where I do unilateral infraoblique enterization, I try to keep it like this, and then if there is still a persistent infraoblique overaction, I will try to pull it back. So it is reverse, not as we do lateral rectus surgery, where if there is some angle or medial rectus where we directly recess depending on the angle. This would be reverse because we are doing enterization. Was it too heavy? Okay, so if you do an infraoblique surgery, you are no, not the muscle, the whole dose of going reverse, indirectly proportional to directly proportional. So when you do infraoblique surgery, you try to bring the eye down. and if the eye is still up, you pull the muscle rather than recessing it. Still heavy. Okay, we'll drop it there. So supraoblique also, we have discussed enough about the personal life of supraoblique. So supraoblique, yes, I was pointing at supraoblique. So now we have hooked the superior rectus and we are trying to hook the supraoblique. And I would show that, supraoblique also, this is only partial muscle which has been hooked and the posterior fibers are still remaining. So we have to go more posterior, but you have to be careful. You have to use a Barbee's retractor. You have to retract and then try to see posterior fibers and hook them. So you can see the vortex vein. It is this here. Here is the this is the vortex vein. So you have see now the whole supraoblique is there. So you see we have made a partial dent in supraoblique. Since we were planning to do a PTSO, it was not much of a problem. We removed those fibers and left 2 mm anteriorly. So supraoblique also you have to be careful. Supraoblique resurgeries are very difficult. I was fortunate enough to see video of Dr. Suma Madam. She showed a supraoblique chicken suture resurgery. But I don't have a similar video. But fibrosis is a big issue. To differentiate between tendon and fibrosis would be very difficult in superior oblique especially. So in weakening procedures, PTSO or expander may extrude. It can be removed. If it is associated with esophageal scenario, better to go for an infraoblique weakening procedure along with that. If it is very tight, as ma'am showed, you can do a chicken suture. If it is there as a chicken suture, we can remove and do a clean tenotomy, and we can add infraoblique depending on the primary position angle. In the tuck, on-table FDT is a must, and in immediate post-op revision and reducing the amount of tuck has to be done. Late post-op, removal of non-absolved suture fibrosis. If you have done a tuck and patient has come to you after, say, somewhere else he has got operated, we have to do a supraoblique weakening procedure like chicken suture. Harada Ito, again, most of the Harada Itos I do are adjustable, so never had a problem, and they are easily reversible early post-op. So you have to be very careful with Harada Ito because you are doing it purely for torsion. Harada Ito is mainly for torsion. It doesn't give you any significant weakening effect in any of the gazes of supraoblique or even in primary position. So you can do adjustable Harada Ito and see torsion, intra-op, post-op. And as Dr. Guyton used to teach, you can take an indirect ophthalmoscope, see the torsion inside the OT. The only thing is it would be with an indirect ophthalmoscope, so it will be reverse picture of what you will be doing. Fundus pictures can always help, not intra-op, but it can help. So this was, I am just showing that we did a tuck and we tried to do a FDT. The only tip is when you do FDT post-tuck, it should, your eye should be able to go just above the punctum. So that's the take-home messages that the first point has been exclusively dealt with. Torsion assessment both subjectively and objectively is very, very important. This gives you very good clues. A lot of times, you see patients where you feel that maybe I can touch infraoblique. If you look at the torsion, it would become very clear whether this particular patient needs infraoblique surgery or not. Resurgeries are pretty difficult in both the scenarios, but still easier in infraoblique. You can do a myectomy at any difficult case, but would be difficult for supraoblique because you may have to think of supraoblique paresis. Dissection should be slow and gentle in all resurgeries. Cut as little because identification is difficult. Thank you so much.